Good evening, ladies and gentlemen, and warm greetings to each and every one of you on behalf of Team DentistChannel.Online. We would like to thank you for attending this live webinar in such a large number from all around the world. We feel so honored to have people from the Middle East, from India, and from Europe eagerly waiting for the live webinar. It's also my privilege to welcome our speaker, Dr. Hazem Torki. Dr. Hazem completed his Masters of Science in Oral Implantology from the prestigious Goethe University in Germany. He is a fellow of the International Congress of Oral Implantology, ICOI, and is a visiting lecturer at the Cairo University. Dr. Torki has lectured both nationally and internationally. He is the owner of Torki's Academy for Continuing Education and Research. His private practice is focused on oral implantology. We're so very privileged and humbled and honored to have you, Dr. Hazem, today. Without much further ado, I now request you to kindly start with the live webinar. Thank you very much.
It's my honor, and happy birthday to you and happy birthday to me.
Thank you very much.
What a coincidence. We have our birthday at the same day on this day for the webinar. And I'm really happy to be joining you with this moment that we can share our knowledge and our experience with the audience worldwide. And I'm really happy for all the efforts that you're doing. And hopefully it will be beneficial for everyone today. So I would like to start with our lecture today, and my birthday, Dr. I share my birthday with you. Okay, I just got from Dr. Dia. I think it's his birthday also. Okay, we're gonna start now. Our topic today, I'm gonna share my screen first. And okay. So just want to make sure that everything's okay, everyone can hear me. And today's topic, we're gonna talk about the implant abutment design and crestal bonus. Actually, these are two parts of implant dentistry that are in big debate. Okay, 1 second, because my team is informing me something. I just want to make sure that everything's okay. I just want to make sure. 1 second. Okay, I think there's only 100 people are trying to go online, but they cannot. So yeah, I think those that are not able to go on Zoom, they can see it on Facebook. And yeah, is this right? Am I right?
Yes, who are able to come to Zoom, they can watch through our YouTube channel. Go to YouTube.
Okay, YouTube channel.
Yeah.
Is it also will it also, and your Facebook page, will it also be live on the Facebook page?
Yes,
or
yes, yes. Facebook page also we have shared the YouTube link.
Okay, there's a YouTube link on the Facebook page.
Yes, yes,
and
yes.
It's called DentistChannel.Online.
Yes, yes. Wherever they go, you can search DentistChannel.Online. Thank you.
Okay, so those who aren't able to join us on Zoom, they can check the link on the Facebook page, and it will be on YouTube. They can see the whole lecture live.
Sure.
Okay, so now to go back to start our lecture. Okay, now just check that it's on the page. There's the link. Okay. Because people are trying to. Okay, is there a link now? I just want to ask the team and Ruben if they can help me. Is there a link that they can? Because on the Facebook page, there is no link until now. So
I'll share the
people
link to
want
you,
to.
sir. I'll share the link to you.
Oh,
You can check now.
okay.
I think
Okay.
must receive now.
Because it's not on the Facebook page. Okay.
YouTube page link I shared with you. You can check it now.
Okay. 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 I sent you that. Okay, I got the link. Yeah.
Please pass to
And
your
it will be live on YouTube. Yes.
Yes, yes, it's already live.
Okay.
Thank you.
So, okay. So now to start, this topic is actually a very interesting topic because from the day we started to place implants in patients, and from the day Brammark they started to treat the first patient, and the first patient was treated with an implant, things were in continuous evolution, we can say, and continuous enhancement in order to reach the goals that we had in every decade, we can see. Because in the first few years of using dental implants as an aid for restorations, it was solely directed, and the main goal of implant treatment was to restore function. And the consequences of that was all the research and all the effort of clinicians back then was just one goal: to provide function for the patients. And they did not look into aesthetics that much. It wasn't the main goal at that time, because the treatment started with oral rehabilitations where patients had complete loss of function, and they wanted to restore that with full arch restorations using implants in the lower jaw or the upper jaw. So the main goal was the implants to osseointegrate. That was the main goal, to achieve successful osseointegration. A few millimeters of bone loss were not a big deal back then, because they wanted to provide function for the patients. But today, the game has totally changed. Now we don't only want function, but we want above that function and aesthetics. And when we're talking about aesthetics, every point or every plan or every procedure of our treatment makes a big difference in our results or in our final treatment. Few millimeters of bone loss will make a big difference in our final treatment. And that's why companies and research and studies are always trying to provide a solution or the best, let's say, design of implant and abutment assembly for the implant treatment and for our patients. And we always have to keep in mind that we are using implants for the patients. We don't choose them according to our likes or what we would love in a design. No, we have to choose it according to what is the best design for our patients, for our final treatment outcome. And also, what we should learn and what we should understand is that when we choose an implant design, we don't marry it. You can change it. You can change it according to the patient, according to the case, which is really important. For immediate loading cases, we should go to certain designs. For one-stage protocol, we can go to other designs. For posterior implants, we can go to different designs. We can choose, or we can use one or two, three maybe implants. It's not always recommended to use many implants because you have to keep up with many components and many, let's say, tools, and we should always try to keep it as simple as possible, but we should be able to use at least 1 or 2 implant systems according to our treatment needs. If we have one implant system that can fulfill all our treatment needs, then we can use it. And that's why it's always up to the clinician to decide what implant design and implant abutment design actually that he can use for his patients or for the patients in general. Now, I'm going to start with a picture that shows a lot about what we have gone through for the past decades in implant treatment. One of them is this picture, and as you can see, the Arsenal team, a few players from the Arsenal team, and you can see Bergkamp, he's enjoyingly taking a picture from his friend with a cell phone. Today, we are sure that the image that was taken through this cell phone is not accepted today. It's not up to our standards today. It's not up to the standards of our needs. We need today high quality, high definition photos and videos. And technology back then wasn't able to provide us with what we can provide today. And back then we can see that they are really enjoying the situation, and Henry next to him, he's really enjoying that he's taking a picture of his friend. It's something new, something not normal to take a moment with a cell phone, but today that's the normal routine we have in our daily life. And this also applies to the evolution of implant designs. In the previous years, implant designs, they had a polished surface, and that was totally normal and totally acceptable. And I just want to, sorry everyone, I'm just trying to make sure. Okay. So today, having a smooth surface, like 2 or 3 millimeters of smooth surface on an implant shoulder, is not acceptable today for many reasons, unless we go with tissue level implants. But we'll talk about that in the lecture. But back then, in the past decades, it was totally normal, and that was actually what they wanted more, is to have an implants with a polished surface. Because what they definitely expected Crestal bone loss, and they definitely expected that 1 or 2 threads from the implant shoulder will be exposed to the oral environment. And therefore, to prevent plaque accumulation to this rough surface, they changed the design to a smooth surface. And when that happens, when that smooth surface is exposed to the oral environment, what will happen is that it will remove the plaque from that smooth surface, and the coincidence or the possibility of plaque accumulation on that smooth surface is a lot less. And therefore, they were really happy with designing implants with smooth surface or polished surface, a polished neck that we can call it. But through the years, our possibility or our studies and research and all the technology that we came up with that enabled us to study the reaction of the marginal bone to implant placement allowed us to expect less Crestal bone loss, and the numbers were going down. And I hope this also for the COVID virus that we're going through now, the numbers should, hopefully it will go down. But that's what they were able to achieve fewer numbers or fewer average or mean values of Crestal bone loss through the years. And that's why they shifted designs to totally rough implants. They stopped using the polished surface. Another reason why they were using polished surface were because they thought that a rough surface, or if we had threads at the implant shoulder, it can cause Crestal bone loss. It can even cause stresses to the Crestal bone and therefore initiate marginal bone loss. And that's why they were not actually reaching a clear understanding on the effects of this rough threads on the marginal bone. But today, it appears that it has no effect on marginal bone loss. In fact, it enhances the stability of the marginal bone. And that's why even companies, different companies, even went to have completely rough implants with threads also on the shoulder, not only a rough surface, but also many threads, we can say, on the implant shoulder. And that evolution improved primary stability, improves the stability of the marginal bone, and therefore we are able to achieve fewer values of mean crestal bone loss through the years. What's really interesting about the topic that we're talking about today is that no one can come on and relate the topic of implant abutment design to crestal bone loss to a certain specialty. We cannot relate it to periodontics only. It has a part in science of periodontics because part of the reason where sometimes crestal bone loss resorbs, as we're going to talk about or see, is biological width and the soft tissue attachment to the implant abutment assembly. And that's strictly periodontics. It is also related to prosthodontics because the material of the prosthetic abutment that we can use, the gingival height of the prosthetic abutment, all these have an effect, a direct effect on marginal or crestal bone stability. The placement depth of an implant is also playing a big role in the effect or the stability of crestal bone, and that is a surgical procedure. So this is strictly a surgical procedure that affects the final outcome. So all these specialties have an effect on our final outcome. And therefore, for us as clinicians that we will treat patients with implants, we need or we have to have enough knowledge from all these three specialties in order to be able to provide the efficient or the successful outcome for our patients. And to start to understand why implants display marginal bone loss, we need to understand osseointegration. In order for us to understand the reason behind crestal bone loss and how to prevent, actually prevent is not the right word because as we will see, we can never prevent crestal bone loss because it happens in every implant we place, actually. If we cannot see crestal bone loss, it doesn't mean it didn't happen. If you cannot see it radiographically, it doesn't mean it didn't happen. If you cannot see it clinically, it also doesn't mean that it didn't happen. So in order for us to understand the reason behind crestal bone loss and how to minimize, the right word to use is to minimize crestal bone loss to a level or to extent that it will have no significance on our final treatment outcome. To achieve that, we need to understand osseointegration. And unfortunately, what we know about or what we knew about osseointegration in the past is not what we know about osseointegration today. And osseointegration is not anymore a direct contact between bone and an implant. There is no direct contact whatsoever. And many studies have showed this in literature reviews, in histological evidence, in lab studies, that there is no direct contact between an implant and the bone. And Albrechtsen, he started to show this theory. And before Albrechtsen, in the late 2000s, in the early 80s, Davies, he started to show evidence and theories why there is no direct contact ever between bone and an implant. And recently, Chapois in 2015, he showed this with his beautiful histological studies of how we have a layer of foreign body multinucleated giant cells. These are multinucleated giant cells that are always present when there is a foreign body around. Their main goal or the main role is to just attach to the foreign body. And it forms a protein layer This protein layer is made up of these foreign body multinucleated giant cells. They form a layer on the implant surface that separates the implant body from the surrounding bone. So this is the first layer that we have that separates the implant body from the bone. We also have an oxide layer that is present around every single implant that is placed. And Davies, Chapois, and Albrechtsen, they all showed that this protein layer is available around every single implant that is placed in any patient. Whether any implant system you use, any surface treatment, they all have this finding that we never see direct contact between bone and an implant. And osseointegration is just a reaction from the body to this foreign body that has been placed. And this reaction can go into two directions. One second. Okay. This direction can go in two directions. Either the body accepts the implant and encapsulates it with bone, which is termed osseointegration, or the body can reject the implant and encapsulates it with soft tissue, what we call spit out rejection or primarily clinical failure, because now the body will reject this implant before the loading period. It will reject it during the healing phase, which is called the primary clinical failure. If the implant was rejected, which of course happens after loading, even by 1 year, 5 years, this is called secondary implant failure or secondary clinical failure. So we can see both situations happening. Now, what led this implant to be rejected is that bone kept resorbing and bone kept on being remodeled to a level that it was completely removed and soft tissue started to take its place. I just want to make sure everything is clear. Okay, there's okay. So I just want to change something here. Okay. Okay, 1 second. Okay. So to continue with that, these are the two options that can go where the body will accept or reject the implant. When it is rejected, crestal bone loss propagates and continues until complete failure of the implant. And we can have a crestal bone loss around an implant of 1 millimeter, and it stops. We can have crestal bone loss of 5 millimeters from a 10 millimeter implant, but then it stops. Or we can have bone loss around the implant, leading to its rejection. So now we go to the spit out rejection. As we can see here, the implant is totally rejected, and as we can see it radiographically, we can see a black area or radiolucent area around the implant, which indicates presence of low bone density or soft tissue. And this is called encapsulation by soft tissue. And this led to the failure of implants. And what it results is that we can actually remove very easily an implant using a tweezer because there's no actual bone formation around the implants. Now, what we want to achieve is successful osseointegration. For us to be able to achieve that, we have to understand how osseointegration starts. And it starts from the moment the implant is inserted into the osteotomy site. And blood will start to be in direct contact with the implant, and then normal healing process, as we've seen by Cardropoli and by others, of the wounds in order for bone formation to happen. And we start to look at the implant part and we start to look at the abutment parts. And we also look closely at the implant abutment junction. Whether do we want platform switching? Do you want a polished surface for the implant? Do you want a narrow abutment profile or a wide abutment profile? What abutment material should we use? All these factors we need to study very well about any implant system that we will start to use for our patients. Now, if we're going to talk about crestal bone loss, there are numbers or measurements for crestal bone loss that allowed us to study the evolution of let's say, or the evolution or the change in implant systems or designs. In order to achieve fewer numbers of crestal bone loss, we have to have a baseline. What numbers are we talking about today? In order in the future, we can change the design of our implants in order to achieve minimal values of crestal bone loss. And since 1981, when Adel, who was the first clinician to measure crestal bone loss and give values for crestal bone loss. And what he measured back in 1981 was he found out that we have 1.2 of mean marginal bone loss in the first year of implant placement. So in the first year of function, what he measured was a 1.2 value of crestal bone loss. And every year after that, 0.1. And then Berkson and Zarb, they found out that we have 0.2 millimeters of crestal bone loss each year after the first year. So imagine 5 years of function of an implant. It was totally normal and successful to have around 3-4 millimeters in the first 5 years. This was one of the success criteria that Berkson and Zarb had proposed. Because back then, as I said in the start of the lecture, the main goal was to achieve function and not aesthetics. If we look at the values of crestal bone loss in the decades after 1981, like in the late 2000s, or let's say in 2010 and 2005, in that period, we can see that we had an average of 0.5 millimeter or 1 millimeter maximum of crestal bone loss in many scientific evidence and studies. Some studies, they showed more crestal bone loss, more average values of crestal bone loss. It could have reached 1.5 millimeters of crestal bone loss. These actually, or this difference in values of crestal bone loss between one study and another is based upon a lot of things. First, the implant system that was used for the study, and for the factors that wasn't taken into consideration, that we did not know about in the past. For instance, we did not put a lot of importance in soft tissue thickness before. We did not put a lot of importance in the effect of platform switching on crestal bone loss. So some of these studies didn't put any of these factors into consideration. And when they were studying, for example, the effect of the connection on crestal bone loss, for instance, the effect of we're having a hex connection or an internal hex or an external hex, they might have not taken into consideration the fact of soft tissue thickness, which could have played a big role in the final values or the mean values of crestal bone loss. Therefore, we cannot take one study and say, okay, this study showed that we have 0.75 of crestal bone loss average in 5 years. Therefore, this is our number. We cannot do that. We have to take many studies and take many, let's say, averages from different implant systems, from different scenarios, from different situations in order to achieve a number that we can talk about today. We can achieve this value of crestal bone loss. And this is what Jimbo and Berkson, they did a beautiful study, and they came out with a mean value for crestal bone loss on that date, which was in 2015. So they said today we can achieve a 95% of implant survival rate after 5 years of function. And we can achieve, after 5 years of function, 1 millimeter of crestal bone loss. And they even measured after 10 years of function. And they found that we can have from 1 to 2 millimeters of mean marginal bone loss. And the survival rate dropped 5% from 90 to 95%. And it's a very good number or good value for 10 years of function. And I believe that after 2015, today in 2020, we can achieve even less than 1 millimeter of crestal bone loss. And sometimes it can go up to half a millimeter and even to a value that has no clinical effect or no significant effect on the clinical outcome of our treatments, because that's we are able to achieve today. That's what led Thomas Lingvicius, when he started to come out with a zero bone loss concept. I don't believe that we can have, or it's not me, but many studies, they don't believe that we can have zero bone loss. But from the way I actually understood the studies and the theories that came up by Bergson, Davis, and Zarb, we can never have zero crestal bone loss, because a reaction from the body to the placement of implants, drilling is a really aggressive procedure for the body. Imagine someone taking your bone and drilling through it. It cannot get more aggressive than that to a human. You cannot be more aggressive to the human bone by drilling to it. So that's the maximum level of aggressiveness we can reach. Imagine you not only drilling, you are drilling, and then you are putting a foreign body inside the bone. What do you expect? How do you expect the bone to react? There has to be a reaction every single time. And that reaction is crestal bone loss, but to an extent. So I believe that we have crestal bone loss around every single implant that is placed in a patient's mouth. But sometimes we can see it and sometimes we don't. So I don't believe in zero bone loss, but I believe in bone loss concepts like Thomas Lingvicius has proposed that can not prevent but minimize the mean values of crestal bone loss. That's what we will talk about today. So to start with, we have to understand that there are two types of failures. There are biological failures, which we can see as crestal bone loss, for example, which can lead to peri-implantitis. It can lead, it's not always this way, because peri-implantitis is not always a disease. So we can have a disease that can lead to crestal bone loss, which will in turn lead to peri-implantitis because it started by a disease. But what if we have crestal bone loss not due to a disease? Can we still call it peri-implantitis? This is a really important question, because the moment we hear the word peri-implantitis, we think about inflammation, we think about disease. This is around teeth when periodontitis is inflammation or due to inflammation and is a result of bone loss around teeth. Now, periodontitis is always due to disease, but peri-implantitis sometimes it could be due to a disease that caused bone loss, but sometimes it's not due to a disease. So now what we're talking about here is, okay, can everyone hear me? Okay, so now what we are talking about is a biological failure that could be due to a disease and could not be due to a disease. Because if we have bone loss due to a foreign body reaction, it's not a disease, but it's a biological failure. So the first failure or type of failure we have is biological failure. The other type of failure that we will talk about is a mechanical failure, as we can see here. The abutment has fractured and all we have left is the screw connecting the abutment to the implant. And in certain type of connections, like cone connections, it's almost impossible, or sometimes it's impossible to remove the remaining part of the abutment, because it's really tight there, and you cannot, sometimes it reaches a level where you cannot use a tool, or it's no longer applicable to use tools to remove that part. So sometimes you have to sacrifice the implant, either remove it or try to find an alternative solution. Sometimes we are able to remove the broken or those fractured components of the abutments. And sometimes we have even more devastating mechanical failures. So there are two types of failures we have to differentiate in order to understand crestal bone loss and osseointegration. We have biological failures and we have mechanical failures. And an example of a mechanical failure that can happen is implant fracture. If we look closely at this image, we can see a crack, we can see a crack in the implant body right here. And what will happen is, with time, we will see flaring of the implant, like it's sometimes called, and the crack will propagate, and now this implant can no longer be in function. It has to be removed. Apart from the aesthetic disaster that we have here, then we need to remove this implant. And the moment this happens, you have lost patient's time, you have lost your time, you have lost patient's trust, or you can start to lose the patient's trust because of a mechanical failure. And also you will have to provide extra costs on yourself and the patients in order to restore again the treatment that you started initially. So we have lost an implant, we have lost an abutment, and we have lost a crown. Imagine the cost of all these three components. We cannot use any of them again. So therefore, we need to find methods and treatment plans and implant designs that would prevent as much as possible complications, because we can never completely prevent complications. We can never completely prevent crestal bone loss in every single implant, but we can minimize to a very big extent in order to provide a more predictable outcome for our patients. And we can also sometimes have implant fractures. And today, many of the studies, they relate the fractures of implants to the diameter of the implants. And a study also by Jimbo, where he showed that, and other clinicians, they also published several studies, and they showed that the frequency of implant fracture is more common in narrow implants, in 3.5 diameter abutments. And it's less frequent in 4 and even 4.5 and 5 millimeter diameters. So this is something really important we have to take into consideration, that in order to prevent implant fractures, wider implants can be our solution. But unfortunately, we cannot always use wider implants. So we have to use a balance between the implant diameter and the mechanical failure possibility. So we have to keep this in mind. Now, we will start to talk about connections, the implant abutment connection. We know we have mainly 3 types of connections that are mostly common or most commonly used today. The hex connection, which can be internal and external connection, and we have a cone connection. So we will start talking about the hex connection, or the butt joint connection is another name, or the flat to flat connection is a third name. There are many names for this connection, and it was the most common connection used by companies in the past decades. And what we was always seeing in x-rays and in final treatments and follow-up treatments or follow-up sessions, that we always find bone loss around the implants, 1 to 2 millimeters of crestal bone loss until the first thread of the implant. And we always used to see or visualize this on the patient clinically or in x-rays radiographically. Our studies kept to ask, why was this happening? Was it related to the connection, or was it related to something else? We will see later. Another type of connection, and by the way, the pattern of crestal bone loss was even given a name called the saucerization of crestal bone, or crater-shaped bone resorption. So because it was always a pattern to have this shape of crestal bolus around internal hex implants and external hex implants. Now, in the late 80s, there evolved another type of connection, which is called the Morse taper or cone connection. And this led to studies comparing the effects of a connection on crestal bolus, because what they found was that when we use a cone or Morse taper connection, we had less amount of mean values of crestal bolus. And what a cone connection is, or a Morse taper, it's another name, is that the degree of taper from the midline to the shoulder of the implant or the edge of the abutment or the inside of the implant, it has a certain degrees of taper. For example, in this system is 5.6 degree. Other systems has 1.5, some have 6, some have 8. It depends on the implant system, and we will talk about this. Now, this is a cone in cone connection, so we have no flat surface. We can have flat surface in that part, which is the index, to enable an easier positioning of the abutment on the implant body. So if we did not have this flat surface, the abutment can rotate 360 degrees around the implant for the positioning or the transfer of the abutment from the cast to the patient's mouth without using a verification jig. And that's why they started to use an index flat surface or a hex connection at the apical part of the abutment. But the abutment itself is a cone connection or Morse taper connection. And you can realize that I intentionally used alternatively the word, or interchangeably, the word Morse taper and the word cone connection. And I was making a mistake for the past few minutes because unfortunately, or not unfortunately, they are not the same. But unfortunately, studies, clinicians, and everyone is using these two names interchangeably, the Morse taper and the cone connection, where in fact they are totally different connections. We cannot call a cone connection a Morse taper connection, and a Morse taper is not a cone connection. For a very simple reason, their degree of taper is different. And Morse taper connection was invented by Stephen Morse. He was a mechanic, and he came out with this connection that had a degree of taper of 1.5 to 2 degrees. Any taper with a degree of taper of 1.5 to 2 is a Morse taper. Any other number other than 1.5 to 2 degrees is not a Morse taper connection. It's simply not, because the inventor of the connection himself, he said that my connection, which I called Morse taper, is 1.5 to 2. We have other tapers with other different names. That could be 4 degrees, 5 degrees, 6 degrees, but they're not called Morse taper connection. And actually, the Morse taper itself, he came out, or after that, it came up with different connections of Morse taper, like Morse taper 1, Morse taper 2, 3, and 4, that have different degree of tapers. So the Morse taper connection is a 1.5 to 2 degrees. And this is what he came out with for machines that used to mill metal. So there had to be precise connections and efficient connections and friction fit connections that can actually mill metal. And that's why he came up with this connection. Unfortunately, until today, studies have been published with a wrong name for the title of a study. Unfortunately, studies are calling cone connection Morse taper connection, and they are accepted for publication. Clinicians are using this name interchangeably. And what's even more problem than that is that companies, they call their implants Morse taper connection when they have a 10 degree of taper, for example. And we need to look at that because this is one of the first parts that some studies are misleading at. The second part is that some studies, they say that, or the companies, they say that their implants are without microgaps. So the first lie is that some companies, they tell us that our implant is a Morse taper, where in fact it is not. And some companies say that our implant has no microgap and therefore no bacterial accumulation, where every implant today has a microgap. Any type of implant in the market, there will always be a microgap between the abutment and the implant, because we cannot reach until today a level of mechanical precision to have two components fit into each other without a gap in between. How can we achieve that? It won't. Today we cannot achieve that. We don't have the precision of machinery to fit two components together without a gap. And therefore, every single system has a microgap. But the size of the microgap is what differs from one system to another. And some studies say that, yes, the size of the microgap can be a role. And some other studies say, whatever the microgap, it doesn't make a difference. And Herman, he showed in one of his studies that the size of the microgap has no effect on crestal bone loss. But some other studies show that if the microgap size was smaller than the size of bacteria, this means that bacteria cannot enter this microgap. And therefore, we won't have bacterial accumulation of the implant-abutment junction. And why this is a theory that can cause crestal bone loss is, imagine you have, let's say, crestal bacteria accumulating inside the implant-abutment junction. The moment you apply loads to the abutment can bend and the gap here will open, and therefore it will suck in all the fluids from the surroundings, including bacteria. And when the load is removed, the gap closes again, because the abutment will then return to its normal position, which therefore will push out or spit out the fluids that entered the abutment. So you're sucking in and pushing it out. This is what we call a tissue pump action, and therefore it was proposed that this can cause bone loss in the marginal bone, in that area around the implant shoulder. So this pushing in and out of the bacteria is called the tissue pump action, and it can cause crestal bone loss in the marginal bone around any implants. But if we have an implant abutment assembly that moves together as much as possible as one unit, then we can minimize this micro movement. It's called a micro movement because we cannot see it by our own eyes. So if we can minimize the micro movement, we can minimize the effect of the microgap or the tissue pump action. Now, in the systems we have today, we have different systems, and each of them has different degree of taper. Most implant systems have a degree of taper above 1.5, like they will fall in that category on the left side, going from ankylose and going upwards towards astra and stroma, taper above 1.5. Only very few systems in our market today, including Bicon, K3 Pro, and I think a third implant. These are it's around 3 or 4 implants in the whole market that has a degree of taper of 1.5 degree. And they are Morse taper connections. I don't believe there's something called as true Morse. Morse is a Morse. There's not. We cannot have a true cell phone, for example. A cell phone is a cell phone. A Morse taper is a Morse taper. Why people invented this name, because that's what I believe, at least. Some of them say we have a cone connection, but then they're in between cone and Morse taper. So they call it a true Morse, just to ensure that they are a Morse connection, where in fact they aren't. A cone connection is a cone connection. A Morse taper is a Morse taper. It's as simple as that. So we cannot have a true hex connection. It is a hex connection. So what advantage of having an implant abutment connection with a degree of taper of 1.5? Actually, the advantage of that is superior precision and friction fit and attachment between the abutment and the implant, to an extent that sometimes we won't need a screw in order to provide retention for this abutment. Imagine if you place an abutment on an implant, remove the screw, in a hex connection, you can easily remove the abutment from the implant. But in a more stable connection, you need a lot more force to remove an abutment from an implant, even without a screw. And that's because it's a very tight, and they call it a cold welding or virtual welding between the abutment and the implants. And therefore, this is where it comes into action. The more stable connection is enhanced mechanical retention and mechanical capabilities of the implant abutment junction. So this is an example of a more stable. This is a K3 Pro implant with a more stable connection. And you can see what most of the time, I think near 100% of more stable implants, you will find platform switching, which is another factor that affects the crestal bone loss. And we will debate about this in the lecture. So what we can achieve with precise or more, let's say, mechanically stable implant abutment junctions is different options for our treatments. Before, we always, what I used to learn, at least from when I started to place implants, is contraindicated to use cantilevers in implant dentistry. It was a total contraindication. And if you read studies from Kalmish in his amazing textbook that will be a guideline for us forever in implant dentistry, he used to mention that it is a contraindication to use cantilevers. But today, using different connections other than hex connections, we can achieve acceptable results for cantilevers with follow-up periods and long-term success. And as we can see in this case, we have no bone loss around our implants. We have a stable marginal bone level around the implant after 3 years of function. Another example, we have also overload on an implant with a high crown to implant ratio. You can see how long the crown is, and yet we have a stable crestal bone level. And we can only achieve that through a superior mechanical composition or a superior abutment junction or implant abutment junction that can translate this to clinical results. So what I'm talking about, or why are we mentioning all this? Because today, the main goal is for you to decide what implant system to use, what treatment protocol to use, will you use a cantilever or not? It's not based on anyone's decision. It's on your decision, what's the best for the patients. Where you will take this decision from is from clinical evidence and scientific evidence and from your clinical experience. So you need to make decisions that are best for the patients. I cannot tell you it's contraindicated to use cantilevers because there are studies that can show or shows that cantilevers are not a contraindication. We can achieve successful results with it, but you have to do your own research. You have to find out whether you can apply this technique or treatment protocol for the patient. The same goes to immediate clothing. The same goes to the socket shield technique. The same goes to any technique using tie mesh for guided bone regenerations. You have to decide by your own what technique that is best for the patients and your patients. Whether should I go for a hex connection, for a more stable connection, for a cone connection, it's your decision. Now, someone can tell me, but when we have overload on an implant, it will cause crestal bone loss. Well, this is partially right, because what we learn from scientific evidence and from clinical experience is that overload will only cause crestal bone loss if it was accompanied by inflammation. And that's what Kozlovsky have found out. He made a beautiful animal study where he compared loaded implants without inflammation and with inflammation. And the worst scenario that you can have, or actually the only time where you'll have bone loss, is if you have inflammation, whether loaded or unloaded. If you have an overload on an implant and inflammation, this is the maximum amount of bone loss that you will get. So what clinical relevance does this have to have on our daily practice? Well, what it has is that if you expect inflammation to happen for your patient one day in this lifetime of an implant, or let's make it more simple, if you expect that your patient has a bad oral hygiene and will not improve it in the future, then you have to avoid overload as much as possible. Because if you have overload and you have inflammation, your implant will definitely fail 100%. That's what all studies showed. When you have overloads and we have inflammation, it will only cause implant failure. So now we will go to another factor that can affect crestal bone loss stability. We talked about the implant abutment junction. We talked about the connection. And now we're going to talk about the abutment material. And I'm going through several factors because actually it's a lot of factors, and crestal bone loss is not it's not depending on one factor. It's a multifactorial finding that or phenomenon that we see, because there's at least 10 factors that can play a role in crestal bone loss. And that's why it's very hard to minimize crestal bone loss, because you need to take into consideration of all these factors in every single implant you place. So it needs a lot of knowledge and a lot of experience. But it's possible. Today, it is possible to achieve very, let's say, successful outcomes for implant or for crestal bone loss. Another factor, so the first factor is the abutment material. Before, the most common abutment material was titanium, commercially pure titanium. And today, it's we can say it's the most common abutment material that we can use. But in the past decade, there emerged zirconia abutments, on customized zirconia abutments on tie basis. And that have been proven to have better environment for the peri-implant tissue, and therefore better crestal bone stability. Because if I have a good attachment from tissue to the abutment, it means that the biological width was respected, and therefore the crestal bone level will be stable for a long-term period. That's what Lengvicius has showed in his beautiful studies about the attachments of tissues to polished zirconia. And it showed better clinical results and histological results than to titanium and other materials such as PEEK, for example, or composites. So someone can tell me this means that every abutment we should use should be a zirconia abutment. Actually, no. Sometimes we use titanium abutments and it's perfectly good. We have no problems with that. But if you want to minimize as much as possible, especially in a highly aesthetic case, the bone level or the bone loss that we have, then it will be better to go towards a customized, highly polished zirconia abutment on a tie base, because that has been proven to provide the most predictable attachment, or the most, let's say, advantages of biological attachment to the implant abutment junction. So that's what we want. We want a strong attachment of tissue, of peri-implant tissue to an abutment in order to protect osseointegration. And that's the function of biological width. It's protection of osseointegration. When does biological width start to form? The moment an implant is exposed to the oral environment, whether it's at implant placement or 3 months after, At second stage surgery, the moment the implant is exposed to the oral environment, what we will see is crestal bone loss. Is biological width formation. So now, if there is enough soft tissue volume for biological width formation, it will form on the abutment surface. If there is not enough volume of soft tissue for biological width formation, there has to be. What will happen is that bone will resorb to provide volume or space for biological width formation. So we have crestal bone loss that happened to provide space for biological width formation. And then it won't form on the abutment. The peri-implant tissues won't be attached to the abutment body. It will be attached to the implant surface. This is what we don't want. We don't want that. We don't want any soft tissue on an implant body. What we always want is bone to be covering totally our implants. That led to, I don't know why some companies try to alter the implant shoulder in order to improve tissue attachment. The only reason that would be is because they expect bone loss, and therefore when it happens, they want soft tissue to attach to the implant surface. But if we don't expect bone loss, we know that the implant will be totally covered by bone. We want the soft tissue attachment to be completely on the abutment, what is called supracrestal biological width formation. And we know what biological width is composed of: the connective tissue components and the junctional epithelium, or the epithelial attachments. That's what forms the biological width. So how much thickness that we need? The amount of thickness that we need for biological width formation was totally different in the past decades than today. Now, another factor that plays an important role in crestal bone stability is platform switching. And as we said, what is platform switching? Quickly, those who doesn't know about it, is that there's a mismatch between the abutment diameter and the implant diameter, where the implant diameter is not, the implant diameter is wider than the abutment diameter, and you have the shoulder of the exposed implant, let's say exposed titanium to bone, to soft tissue, for bone to grow over it, like we can see in this histological cross section. What does this have an effect, or what effect does it have on clinical outcome? Well, what platform switching does, you see, if you have the connection here, then your microgap that we have talked about earlier will be in direct contact with the crestal bone. What platform switching does is it causes a horizontal offset or shift of the microgap from here to an inward area away from the crestal bone. So this is where we have the microgap, and this is where we have our crest of the bone or implant shoulder. Someone can tell me now, how come the microgap is here and we have crestal bone here, or bone formation on the microgap? Actually, this will not continue like that. If you look at this situation after 3-4 years or 1 year in a histological study, you will find the bone level to be here, which is completely acceptable. That's no problem at all. We don't need bone to be on the abutment itself. We want it to be on the implant. We want all this to be covered with soft tissue. That's perfectly fine. If you have a result like this, it's even better, but it doesn't happen a lot. So what effect does this have? If we have, let's say now that I shifted the microgap away from the crestal bone. Why, when the microgap is close to the crest of the bone, does it cause crestal bone loss? For one simple reason: we have a microgap, we have bacteria. Bacteria is in close contact to bone, bone will resorb. It's simple as that. And what Erickson has showed us is that bone will always stay away from inflammatory cells by 1 millimeters at least. And that's what he showed us here. This is the bone, and this is inflammatory cells. This is soft tissue, sorry, and this is the inflammatory cells related to the implant abutment junction. Bone will always stay away from inflammatory cells by at least 1 millimeter. And if bone was here, let's say starting at this area where the inflammatory cells are here, it has to stay, it has to be protected by soft tissue in order to protect bone from inflammatory cells. So the role of this band of soft tissue is to protect bone from inflammatory cells. Now, knowing this is a very important point of information because this 1 millimeter plays a role in a lot of things, even in implant design. So this is the implant abutment inflammatory cell infiltrate, which Erickson has called the A or the abutment inflammatory cell infiltrate. It's not plaque induced, it's abutment implant junction induced. So this is plaque induced inflammatory cell infiltrate, and this is from the implant abutment junction. So if I was able to move, now concentrate on this, because if I was able to move the implant abutment junction 2 millimeters away from the crest of the bone, this means that the inflammatory cells are away from the bone by 2 millimeters. Will bone need to resorb? No, because it's already away from inflammatory cells. Do I have enough volume for biological growth formation? Yes, I have enough thickness for biological growth formation. Then we can predict stability of crestal bone levels. Now, another factor that can affect your crestal bone stability is the abutment height, actually. And this is what Blanco have showed in 2017, that when using implants with different abutment heights, the shorter you go, the more possibility of crestal bone loss. And in these two examples, this is a 1 millimeter gingival height of an abutment, and this is a 3 millimeter. We had crestal bone stability in both situations. Why do you think this happens? There has to be a reason why I achieved crestal bone stability in a 1 millimeter gingival height abutment and a 3 millimeter gingival height of abutments. What we had here is that other factors that can cause crestal bone loss was respected, or mainly all factors that can cause crestal bone loss was respected. Soft tissue thickness, platform switching, microgap moving away from the implant, from the crest of the bone, the load, inflammation, everything was respected. And therefore, we can, in a case like this, use a 1 millimeter gingival height of an abutment. Because we have deep platform switching. You can see how deep this platform switches. It's not as deep as this one. So let's imagine we have the same thickness of soft tissue in both cases. If I had 3 millimeters of tissue thickness, or so let's say 2 millimeters of tissue thickness here and here, but I have a deeper platform switch this implant. Therefore, I've created more volume over the 2 millimeters. Therefore, 1 millimeter would be enough. But if I have the same thickness without platform switching, 1 millimeter will not be enough. You'll have to thicken your tissue in order to be able to use a longer abutment gingival height. You see where this is going? You can play with many things. You can play with the abutment implant design. You can play with the soft tissue thickness. You can play with the subcrestal position of your implants. On this case, I had thick tissue. Why can I say I have thick tissue in a case like this? Because I was able to use a 3 millimeter gingival height abutment. Otherwise, if I have thin tissue and I use a 3 millimeter, then what this translates to is that the finish line of the abutment will be above the tissue level by 1 or 2 millimeters, which is aesthetically not accepted. So I have my soft tissue thickness at least in that area, and I have enough volume for biological width formation And the biological width actually here, or the peri-implant attachment, I can expect to be on the abutment surface, not on the implant surface. That's why the crestal bone level was stable. That's why Blanco have concluded that the longer the implant, the abutment height, the better crestal bone stability to an extent. We need to go for a 3 millimeters as much as possible. This means that the whole the peri-implant tissue attachment will be on the abutment and not the implants. If I have thin tissue and a 1 millimeter of gingival height, then if I have only 1 millimeter, let's say I have 1 millimeter of tissue thickness, and therefore I will use a gingival height of 1 millimeter because I want the finish line to be equigingival. What will this provide you? And you place your implant at a crestal level, equicrestal. So you have 1 millimeter of tissue thickness and you have 1 millimeter of abutment height. Where is the remaining 1 millimeter or 2 millimeters for biological width formation? Where will it form? Bone will have to resorb for formation of biological width. And therefore, you will have half of the attachment of soft tissue on the implant and half on the abutment. And that's called subcrestal biological width formation, which we do not want to achieve. And imagine this implant bone and the papilla in between them. If I used a hex connection in a situation like this, the microgap will be direct contact with the bone, inter-implant bone, and therefore this bone will resorb, and also in here, this bone will resorb. So what will happen to this bone is that it will collapse. Instead of following this pattern, it will follow this pattern. So what will happen to the papilla? It will collapse too. Then you get a black triangle between your implants because it resulted in a subcrestal biological width formation. A method to prevent this is from using platform switched implants. Is from thickening or making sure you have thick tissue to start with. Is to place your implant in a subcrestal position. All these factors, they play a role in order for you to be able to achieve a peri-implant attachment on the abutment, not on the implant surface. We don't want tissue on our implants. We want bone. We want tissue on the abutment. The only way or place the tissue should be is on the abutment. And also here we have the biological formation on the abutment itself. You see what this has. And now, this is where it came from, the one-time-one abutment concept. Because if I remove this abutment, I will cut the attachment that is formed. There's a big debate about whether it has a clinical significance or not. But from the point I see it, we can utilize this technique in anterior aesthetic cases where it will make a difference sometimes, because we do not want to remove and place the abutment and keep cutting this attachment the moment it's reformed, we cut it, which can lead eventually to recession. That's what Erickson and Bergson and others have shown, and Degedi have shown that in the one-time-one abutment concept. Now, that's a technique or a tool that you have in your hand you can use whenever you need for your patient. In a posterior case with a 4 millimeters of thickness of tissue, I don't believe it will make a difference if you remove or place an implant several times. And that also change in design from platform switching and narrow abutments and the taper of the shoulder of the implant, they all led to a concept called the socket chamber effect. And Degedi has started to talk about this, and also Rodriguez, he showed us that socket chamber effect can have an effect on your final outcome. What is the socket chamber effect? It is a chamber of blood clots formation. a space or a volume which allows more blood clot to form and more soft tissue formation, and more volume from biological width formation. And it's decided the moment we place an implant in an immediately placed implant, for example, on a socket, an extraction socket. We get a socket chamber effect by having platform switching and narrow abutment. This is very important because imagine you have a diverging abutment with diverging walls that goes to this profile. Then you have less space where you can achieve the socket chamber concept. Now, the main advantage of the socket chamber concept is not only it provides more volume for biological width formation, but it increases the space for fibroblasts. And the fibroblasts, they form or they transform to myofibroblasts. And they are responsible for the contraction of collagen in healing during the healing phase of a wound. The myofibroblast is what causes the contraction of the collagen fibers. And when this happens, the contraction happens, it will form and stop around the widest part, which is the implant shoulder. What is wider than the abutment diameter is the implant. So it will form and stop here. And therefore, the connective tissue attachment will stop at this level. And as we know from the function of connective tissue in a biological width or in protection is to prevent the apical migration of epithelium or the junction epithelium. And that's the most important function of connective tissue, is to prevent epithelium from migrating apically, causing bone loss. That the attachment of connective tissue will stop here, then therefore the epithelial attachment will be on a superior level on the abutment itself. And all this, the socket chamber concept, due to platform switching and narrow abutment diameter or narrow abutment profile, which Rodriguez have shown in his recent studies, it's always better to have a narrow abutment profile than a wider one. All this translates into the socket chamber effect. All this translates into more space for biological formation. All this translates into stability of crestal bone loss due to the contraction of collagen fibers on the implant shoulder. And this is how a design of the implant can allow for that. You have narrow implants. Some systems, they have the abutment diverge in this way, in a diverging area. So we removed the function of the socket chamber or the advantages of the socket chamber effects. Now, this is also another example showing that is what forms this socket chamber effect. And it's really important or really useful, we can see, or it plays a lot of advantage in stabilizing the crestal bone level. So yes, the socket chamber effect can affect the stability of crestal bone level because it provides more space for biological growth formation, and it restricts the formation of connective tissue on the implant shoulder, not on the implant body, and therefore prevent the apical migration of epithelial cells. Now, another topic or factor that can affect crestal bone level is soft tissue thickness. We have a lot of questions, so we'll keep all the questions to the end, and we'll try as much as possible to take also questions from those who are watching us on another platform, but we'll try to manage that. So, soft tissue thickness. Of course, it is the number one factor that you should look at whenever you place an implant in order to minimize the crestal bone loss. This is the number one factor because it's the most important. Why? Because if I have any implant design, and I have thick tissue, I can achieve crestal bone stability. But if I have thin tissue, I won't be able to achieve crestal bone stability with any implant design. So if I have thin tissue, I can thicken it and use any implant I want. But if I have thin tissue and I cannot thicken the tissue, there are certain types of implant that we have to use. For example, totally rough implants. Then I have to place my implants in a subcrestal position. It has to have platform switching. And then I can manipulate with whether this thin tissue will cause crestal bone loss or not. So we will see what research can tell us about that. So how do you measure the vertical thickness of tissue? I'm not talking about the horizontal thickness. I'm talking about the vertical tissue thickness on the crest of bone. How do we measure it? Using a periodontal probe, you start by opening or raising the buccal flap only and leave the lingual flap intact. And then you measure the thickness of tissue with a periodontal probe. This is your vertical soft tissue thickness. We can also measure it that way. After you measure your soft tissue thickness, then you can elevate your lingual flap in order to place your implants. And this is a fatal mistake, by the way, a surgical tip. You can never place an implant unless you raise both the buccal and lingual flap. Because imagine you have a ridge, and this is the lingual flap. We raised only the buccal flap to measure the vertical height of tissue. And then I started to drill. Where is the middle of the ridge in my imagination when I'm drilling? It's here. Because half of the bone crest is covered by lingual flap. But that's actually not the real middle. The real middle is here. And I can only precisely see it when I raise the full flap, buccal and lingual, to visualize the whole width of bone, crestal width. And therefore I can decide where the middle of the buccal of the starting site should be. Okay, to go back. Now, what thickness? We now know how to measure it. Then what? I measured it was 2 millimeters. Then what should I be happy? Should I be sad? Should I worry? It was 1 millimeter, 3 millimeters, 4 millimeters. What's the clinical relevance of measuring the tissue thickness? And how much of tissue thickness do I need? Well, the tissue thickness that we need, and by the way, you can see in the image behind me that I've elevated. I don't know if I can go this way. Now, elevating the lingual and the buccal flap, I can see clearly the whole dimension of the buccal of the crest of the ridge. And now I can precisely manipulate or know where to place my osseointegration site to be exactly in the center of the ridge. If I have that part covered, my implant would definitely be more buccal placed, and it would be a disaster. So now I am able to measure the thickness of soft tissue. I measured the thickness, and then I raised my lingual flap. What should I do? For example, I found out that it was 2 millimeters. Clinically, what should I do? I'm following scientific evidence. I'm measuring my vertical soft tissue thickness. Then what? Should I place my implant in a crestal position? Should I place it subcrestally? Should I use a platform switched implant? Or it doesn't matter? And when does it not matter? What should I do with the implant? What should I provide? What treatment should I provide to the patient? Subcrestal implant placement. In order for you to take these decisions, you have to know why we need to place sometimes implants in a subcrestal position and what effect does the thickness of soft tissue has on crestal bone loss. First of all, how much thickness do we need? Then it will help you to take your decisions. Abramson in 1997, he was the first clinician to measure and conclude that we need at least 2 millimeters of height for junction epithelium and 1 millimeters for connective tissue attachments. So that's 3 millimeters. We need 3 millimeters minimum of vertical height for crestal bone stability and for biological width formation. If you have 2 millimeters, then there's something has to be done. Whether an implant design has to be changed or used accordingly, whether you place your implant subcrestally to gain more tissue height, whether to utilize an implant with platform switching. All these factors, you have to take a decision the moment you realize you have less than 3 millimeters of soft tissue thickness. This has to be something done. You cannot go like that. If you don't do anything, if you place an implant, hex connection implant, in a crestal position or a supracrestal position with a 2 millimeters of thickness of soft tissue, 100% definitely will have crestal bone loss of at least 1 millimeters. And this we don't want to, because it can propagate. Someone can tell me, is it a big deal to have 1 millimeters of crestal bone loss? I have it a lot. It happens a lot in my cases. They can tell me that. I have many cases with 1 millimeters of crestal bone loss. I haven't seen any complications. Yes, sometimes it will pass in a posterior case, for example. Sometimes if you have implant threads exposure, not the finished line of the abutment is exposed, but the implant threads is exposed by 2 millimeters, and yet it can be in function for many years. Yes, of course, this happens a lot, but it is a very high risk case where you can have more bone loss to happen through the years. So what we try to do, preserve the crestal bone as much as possible, even if it will not have an effect or aesthetic outcome on our patients. But we need to preserve it in order to prevent it to happen or propagate in the further years, or continue to happen after 5 and 10 years, 20 years, or 30 years. By the way, what is the lifetime of our implants? Like when a patient asks us, how long will this implant be in service for me? What should you tell him? Lifetime? I don't think so. Like, we're having problems preserving a millimeter of bone. So I don't think so that we can provide a lifetime treatment for a patient without maintenance, at least. Actually, a lot of studies, they propose that the lifetime of an implant is around 30 years. And I believe it's only logic, because after that, components will start to wear down. They will need replacements. I don't mean that the implant will deosseointegrate, but the abutment can fracture, for example. The screw holding the abutment can fracture. The crown can fracture. There will be some maintenance. And that's what orthopedics, they inform their patients, that their implants that they place in the arms or legs of a patient, they are not lifetime. They have to be removed at a certain stage, or they have to be changed, because you will not stay with them for your lifetime. That's what we should inform our patients. Implants is not a lifetime treatment, but it won't fall out, but it will need some sort of maintenance and corrections in the future. We might need to change the abutments. We might need to change the screw or the prosthetic screw. We might need to change the crown. So to go back, we are struggling to preserve crestal bone. And in order to do that, we need to have a minimum thickness of 3 millimeters, and that's what Abramson showed us. If I don't have 3 millimeters, this is what will happen. Soft tissue encapsulation of the shoulder of the implant in order for biological width to form. Okay, now I have, and this is actually the clinical picture. I've took this picture with a microscope to try to show what happens when we have thin tissue. When I have 2 millimeters or 1 millimeter, there has to be more volume of soft tissue. Where will it come from? Bone will resorb and tissue will form around the implant. Now we have 3 millimeters of soft tissue. Let's say 2 in the flap and 1 millimeter of bone loss. And this is soft tissue forming around my implant body. This is soft tissue encapsulation for the coronal parts. In order to prevent this, give the soft tissue the space it needs from the start. Now, can I use platform switching to minimize crestal bone loss in thin tissue? Someone can tell me, okay, you have thin tissue, you have 2 millimeters. We have 2.5 millimeters. Now I need 0.5 millimeter. I can utilize an implant with platform switching, which will give me this extra 0.5 millimeter. Or I have 2, I can utilize a platform switching implant, which will give me this extra 1 millimeter. seems logic. But studies from Linkevicius, he showed us, actually, this is not possible. And when he showed us that even with implants with platform switching, we get crestal bone loss. And then he changed the implant system and used another implant system. And he showed that even though we use implant with platform switching, we also get crestal bone instability and crestal bone loss. But I won't take these two studies as a guideline for my treatment for a very simple reason that Linkevicius himself has showed in the start. You see, if we look closely at this design of implant, it was a biomet Prevail implant. And if you look closely at the design of the implant, you have wide shoulders. This is a disaster today. We don't use these implants anymore because they will cause bone loss. They have a lot of stress on the crestal bone. Imagine you prepared an implant osteotomy site with this width, and then you're trying to squeeze in an implant with this dimension. And actually, the diameter of the platform of this implant is wider than the implant body itself. Like this has a platform of 5 millimeters and an implant body of 4 millimeters. And the implant, the abutment, is the same width as the implant body. So imagine the platform switching is that the abutment should be narrower than the implant diameter. But what we have here is that the implant diameter is the same as the abutment diameter, but we have a wide platform. So what will happen here is crestal bone loss, not due to tissue thickness, not due to we have platforms. Yes, we have platform switching, but you are causing bone loss to the crest of the bone. And that's why he changed the implant system and then study after that in 2014. I don't know why he initially used an implant design in this way. Maybe that's the problem. I don't want to say anything, but it could be bias, it could be preferability of a system. I don't know why, where you have to measure the effects of platform switching on crestal bone level, you need to stabilize or remove all other factors that can affect crestal bone loss stability or crestal bone loss. Like you need to minimize the effect of microgap, you need to use the same connection, you need to minimize the effect of load without inflammation, you need to remove all other factors, exclude other factors that can cause bone loss. And then when he changed to an ITI Straumann implant, he also concluded that platform switching will not reduce bone loss in thin tissue. Why? Because he used a bone level tapered implant from Straumann. And the bone level from its name is bone level. You cannot go subcrestal. You just can't place a bone level implant. It's not designed for that. You can place it maximum 1 millimeter below the crestal bone, but you cannot go for 2 or 3 millimeters, for example. So what this does is that, yes, he used a platform switched implant and he chose the minimal amount of platform switch in any implants these days. Platform in Straumann, they don't have a wide platform switch. They have very narrow platform switch, like say 0.4 or 0.5 millimeters maximum. It goes more with the wider implants we will see. But he not only chose an implant with a shallow platform switch, but he also placed the implant in a crestal position. It wasn't subcrestal. And that's why when we use a platform switch implant in a subcrestal position, studies have shown it can stabilize bone levels. In this study, it didn't. And yes, his conclusion was right for this study because he placed the implants in an equicrestal position. So what we can conclude from his study is that if you utilize a platform switch implant in a crestal level, it won't prevent bone loss in thin tissue. And that's actually where we don't use, when we use a platform switch implant or totally rough implant, we usually want to place it in a subcrestal position to take advantage of that. So if we have an implant with a platform switch and we place it in a crestal level, do not expect it to prevent bone loss. Now, how much or how the depth of platform switch will have a role. Another factor, as I said, he used an implant with shallow platform switch. The Straumann implants, they have shallow platform switch. And other systems, they have 10 times as much of platform switch in their designs. So does that make a difference? Yes, Kanula have showed us in his beautiful study, 2009, he showed us that the greater the mismatch, the less bone loss. The moment you start with a no mismatch and you end up with a mismatch of 0.85, what's the difference? With an hex connection, for example, and a more stable cone connection, either this or this, with an 0.8 millimeters of mismatch. What do you expect for this? Okay, what if we take a 0.5 millimeter of platform switch? Now, I'll ask my team, Ruben and all the team with us, if is it possible that we can make a poll? I want to ask now all our audience, would you go for a platform switched implants that is totally rough, or would you go for a non-platform switched implants for your routine dental work?
We can definitely go for a poll, doctor. You want to go right now?
Yeah, we want to propose it right now. If we go for a platform switch implant, or no, yes or no, for our routine daily work in implant dentistry.
Okay, maybe what the participants can do is they can message us on the chat box.
Yes.
Yeah.
Okay, so we would come up with a poll and find out. I just want to find out and discuss this at the end of the lecture. So what if we have a 0.5 millimeter of mismatch? Will we achieve the same amount of crestal bone stability as if we have 0.85? As if we have 1 millimeter, 1.5? We'll see about that. What Kanula showed is no. The greater the mismatch, the less amount of crestal bone loss we have. If we have no mismatch, like in hex connections, we have 1.5 millimeters of crestal bone loss. We expect 1.5. If I go to a mismatch of 0.8, we have 0.6 millimeters. That's half the amount of bone loss. So if you want to enhance or minimize, let's say, the crestal bone loss, use an implant abutment design with a greater mismatch. That's really important because someone can come and tell me, I've used the platform, and a lot of studies, actually one of them is Linkvicious studies, and a lot of studies, they say platform switching does not prevent bone loss. They use a platform switch implant, and they say, okay, we have a platform switch implant and we have crestal bone loss. And a lot of clinicians until today, they debate about this topic. Platform switching does not affect my final clinical outcome, or I don't need to use platform switching. And a lot of you might think like that. That's why I wanted to see the poll, see the result of that. So platform switching, yes, if you have a 0.5 millimeter of platform switching and you have 2 millimeters of thickness, don't expect this to protect you or to save you. Why? If you go back to what Erickson has showed us, you need always the bone to be 1 millimeter away from inflammatory cells. So if the platform switching is moving you 0.5 millimeter, you're still 0.5 millimeter close to the inflammatory cells. The microgap is still close to the bone. Even though you have thick tissue, it can cause bone loss. Even if you have 2 millimeters of thick tissue or 3. So in order for the microgap to not have an effect and platform switch to play an effect, you need thick tissue and you need a good depth or width of or thickness of platform switching effects. So these two things you should put into consideration. Actually, 3 of them: the subcrestal implant placement, platform switching, and tissue thickness. And the number 1 factor we will look at is the tissue thickness, and then we will look at the remaining things before any treatments. In order to provide more space and more volume for biological width formation, we can place our implant in a subcrestal position, as we said. What this does is imagine I have 2 millimeters of tissue thickness. If I place it in a subcrestal position, let's say 2 millimeters subcrestal, then I have 4 millimeters for biological width formation. I cannot do that with a polished implant design. I cannot do that. It cannot be done with a polished implant shoulder. It has to be totally rough. Then I can place it subcrestal. And then it has to be platform switched. So it has to be a cone connection or a more stable connection. They're not the same as you said. It has to have platform switching and it has to be totally rough. Some designs that are, I believe there are awful designs of implants that they are hex and totally rough. Like if it's a hex implant, then the microgap without platform switching, it will be directly in contact with the bone. How can you put the implant? Why do you need it to be totally rough? You will never place it subcrestally. And these implants, I believe they're not at all scientifically backed up or evidence backed up. So we shouldn't utilize implants in such designs. So we need to utilize implants with platform switching, totally rough implants, in order to be able to place them subcrestal. And therefore, we will have thicker tissue without the need of another surgery or a biomaterial to thicken the tissue. And as we can see here, bone actually forms on top of the implant, and that's the main disadvantage of placing an implant in a subcrestal position, because it's really sometimes a headache in the second stage surgery to remove all that bone. And sometimes we need to use a bone profile if it's available in the system, which some systems they have that bone profile to shape the bone above the implant in order before taking impression, in order for you to place an abutment without any problems. That's why it's preferred when you place an implant subcrestally, you utilize the one-stage protocol. So you place a healing abutment at the time of implant placement, so you do not get bone formation on the implant. You will have the healing abutment preventing bone overgrowth over your implant body, which will make it a lot easier at impression taking procedures and in the prosthetic steps. So if you're a surgeon that are placing implants for a prosthodontist to restore, you have to put in mind into this consideration to make his life easier. And I believe is the beauty of implant is not in placing them, but in restoring them. So I wouldn't want another clinician to restore an implant I've placed. I would always want myself to restore them. That's what we teach our students when we show them the mistakes that they do or the complications that can happen. It always happens in the prosthetic situations or prosthetic phase. And that's why I would never let my student to place an implant and just leave it like that. He has to restore it himself. That's what we do in all our courses that we train our patients with. Now, if we go to clinical radiographic evidence of platform switching, what do they provide? Yes, they will provide more volume for soft tissue formation and biological width formation. And yes, they will allow tissue attachment to be on the abutment and not on the implant itself. When you use an implant without platform switching, this is what you expect. A saucerization of the bone. And it was normal. This phenomenon of saucer-shaped defect on an X-ray was totally normal back then. It's not, that's normal. I've seen a saucer shape. Okay, well, there's nothing I can do. It was accepted back then in the 90s like a routine finding that there's nothing you would do about it. But today, when you see a result like this, especially in anterior aesthetic cases, it could be a disaster. Now, where is the biological width formation here? It's on the implant body, totally on the implant body, or most of it is on the implant body. And that means that the tissue level is more apical than it should be. That means we have recession. This translates to an aesthetic problem, which later on can be translated to a biological problem or not. We cannot expect that. We cannot predict that very much. But what we know, we try to stabilize our crestal bone as much as possible. That's our main goal. That's what I'm trying to help you to achieve, is to show you the factors, or the important fact, the most important factors that can affect the crestal bone stability, and how you can change the way you choose an implant system, how you change the way you place your implants, and how you change the way you manipulate to the tissue that you have. Of course, if I see that the implant system that I'm using and the tissue thickness that I have is not enough for this implant system, then go ahead, thicken the tissue. Utilize a connective tissue graft or alloderm or acellular dermal matrix. Utilize any of these materials in order to increase your tissue thickness from 2 millimeters to 4 millimeters. And then you will have successful results according to the implant system you're using, according to the design of the implant you have. That's why you need to understand both very well. Now, in order to summarize or come up with a conclusion for today, before we have a lot of questions, so I want to give them time. We have 4 main conclusions. The most important factors that can affect crestal bone stability is the vertical soft tissue thickness. And then the implant design, which is talking about the platform switching and the abutment, implant abutment junction, and the rough surface. And the third factor is the ability to be able to place the implant in a subcrestal position. It's really important because it's really helpful during the surgery to place your implant in a subcrestal position. Number one, it can provide more volume for tissue thickness, it can enhance your emergence profile, and it can prevent you from utilizing biomaterials in an excessive way, where you can place your implants in the widest part of the bridge, in limit not to affect your emergence profile. But the most important is the body's own reaction. And unfortunately, we have no role in that. Sometimes, if it's due to medical condition, we have a role in that. But like, for example, the studies are emerging today about talking about the effect of vitamin D deficiency on crestal bone loss or implant failure or success, actually. Sometimes patients with vitamin D deficiency, they can have a reaction from the body to reject the implant. Although some studies, there are a big debate about this, some studies showing that there actually not clear evidence that if a patient with vitamin D deficiency will definitely have implant failure, because I had some patients with vitamin D levels around 2 or 3, and they had vitamin D deficiency and the implants were still osseointegrated, and others, they failed. So there's not clear relation today, but we can expect that the success rate, or the survival rate to be precise, the survival rate of implants may decrease with vitamin D deficiency, for example. Patients that are smokers, heavy smokers, all these factors can vary. So the body's own reaction can cause crestal bone loss without no reason. It's just a foreign body reaction. We have no role in that. But what we try to do is minimize all the other factors that us as clinicians, has a role in. But the foreign body reaction, we leave it, and it should be 1 to 2% that implants can fail due to a foreign body reaction. Above, if your failure rate is above 1 to 2%, and nobody can come and tell me I have 0 failure rate, it's impossible. Then it means you didn't place implants at all. So having 1 to 2% of failure rate is acceptable. Above that, then there's a problem with one of these factors and other factors like surgeries and things that will cause implant failure, inflammation, and the surgical protocol that you're following, the implant position, the 3-dimensional implant position, whether you have infection, a lot of factors you need to worry about and start revising your procedures and revising your protocols in order to bring back the failure rate back to normal. So I hope that this lecture enlightened you with ways to think about factors that can affect the implant abutment junction environment and how to stabilize this environment as much as possible. And now we will start looking at the questions. So
Thank you very much, Dr. Hazem, for the lovely
You're
lecture. It
welcome.
was so nice to have you for the lovely presentation. Friends, you have
Okay.
close to 2 minutes from now to post your questions. We will give you 2 minutes from now. Dr. Hazem, I now request you to kindly stop your screen share. Stop your screen share for a moment,
Okay.
please.
Okay.
Thank you very much, Doctor.
You're welcome. And thank you for all your efforts.
Thank you very
And
much. Thank you very much,
yeah,
friends. It's a very special day. It's a very special day for Dr. Hazem. He celebrates his birthday today. As a
yeah,
token
along
of
with the
as a token of
along with Ruben.
gratitude on behalf of team DentistChannel.Online, here's a small wishing. Friends, as you all know, Dr. Hazem, on a special day, gave us 2 hours of his valuable time. And I'm sure he's going to give us a good one more hour while he's going to answer the question. That tells us, and rather that shows us how passionate he is for dentistry, how passionate he is about teaching, and how passionate he is about everything in general. Thank you very much, Doctor. Here's a small token of appreciation.
Thank
Of
you very
course, we
much
couldn't
from
we
Dental
couldn't meet,
Channel.
and that's the best we can use. Friends, moving on to the next part. This is about tomorrow's webinar. I request you to kindly register yourselves for tomorrow's webinar. It's a very interesting webinar. We would love to have you as well. The topic is Know Your Implant Connection, which is KYC. Okay. Once again, we have another prolific speaker like Dr. Hazem. He is Dr. Hemang Zala. You can find the registration link in the chat box. Thank you so much. And it's now time for us to move to the much awaited question and answer session.
Thank you for this beautiful gift. I'm sure if we were able to meet, it would have been different. But
Thank you
thank
very
you.
much,
We
sir.
are in a situation where it's the way things are going. So thank you very much for this beautiful thought and beautiful gift from Dentist Channel Online and from Ruben also. Happy birthday to Ruben.
Thank
So
you very much, sir.
happy birthday, and hope you have enjoyed the rest of your day.
Thank you very much. So you too. Also, before I forget, we have a few participants who are also celebrating their birthday. On behalf of Team
Yeah.
Dentist Channel and on behalf of Team and Dr. Hazem, we would like to wish you a very happy birthday. Stay safe and enjoy your quarantine birthday. Thank you very much.
Yeah.
And we now start with the question answers
Okay.
session. Moving on with the first question. Question from Dr. Mansi. Can you please explain the concept of oxide layer?
Okay. The concept of oxide layer is it's actually not a concept, but it's a finding that whenever an implant is removed from the vial and exposed to the environment, an oxide layer is instantaneously formed. And that's titanium cannot be present without oxygen. So it has to be titanium and oxygen, which forms the titanium oxide ion. So there will always be around every single implant, whatever the surface treatment is, an oxide layer on the surface of the treatment of the implant. If you scratch the implant, you remove the oxide layer, it will instantaneously form again. So the titanium will never be there by itself because it oxides. It's an example like you have iron oxide, but iron oxide for it to form, it takes a long time. In implants, it's an instant formation of the oxide layer.
Thank you very much. So moving on to the next question. Question from Dr. Manasi from India. What are the reasons for spit out rejection?
Okay, this is a very beautiful question, yet unfortunately a very tough question to answer because the reason for a spit out rejection could be a lot. Could be technical failure from the dentist or the clinician, surgical problem that he had, malposition of the implant. So a problem in the surgery. It could be a problem in the prosthetic phase. It could be a medical condition, and it could be a foreign body reaction that you have done nothing wrong during the procedure from start to finish, yet the implant fails. And this happens to a lot of us, on all of you, and it happened to me. I placed an implant, and after a few weeks, a few months, the implant is rejected without any reason that I can actually think of. So the reason is a lot. Sometimes it's not in our hands, but we have to reduce the amount or the percentage that it is by our hands.
Thank you very much. So moving on to the next question. Does the implant abutment design gets affected by density of bone from D1 to D4?
So does the implant abutment design gets affected? Actually, the implant abutment design has no relation to the bone density. It's the implant design itself, maybe. So, but the abutment has no role, but the implant design, yes, if I have a density of D3 or D4, I would tend to go for an aggressive implant, a more aggressive implant with deep threads and sharp threads that can provide me more predictable primary stability. So especially if you're following an immediate loading protocol, you need to make sure that this implant, the possibility of immediate loading is high, and therefore utilize an aggressive implant in D3 or D4.
Thank you very much, sir. Moving on to the next question. Question from Dr. Inawati from Dempasar, Bali. I would like to ask you, what preparations should I use to minimize implant rejection? Because in over 60 years, it increased the rejection. Could you give me advice to achieve the successful implantation?
So what I believe from your question, Dr. Inawati, is that in patients over 60, you have increased rejection rates. Well, I would document, first of all, I would advise you and I would recommend and I would propose a recommendation to document every single case you do from now on. And if you have documentation for the previous cases, go ahead, look at them. Because you can only, especially in crestal bone loss and failures of implants, you can only find out the reason of the failure if you look at the previous data that you had during implant placements. Look at the medical history of the patient that this implant failed. Look at the clinical pictures of the surgery itself. Look at the level of the crestal bone height that you have, the landmark where you started with crestal bone, the amount of tissue that you had from the start. So always document in terms of images, clinical images, x-rays, and data. You collect all these information, and then you look at your cases. Look at all of your cases that you've done. What's going on? Why am I having failures? I had this in a certain period of time where I was a bit more, let's say, careless, we can say, in patient selection. And then I looked back at my cases. My failure rate increased slightly when I started to work with implants dentistry. And that was in like 2010 or 9. I found myself, my failure rate was going 2 or 3% more than the 1 to 2% that we should have. And I realized that my patient selection was not that strict. So I increased the patient selection criteria and I made them more strict, and then my success rate became, or survival rate became, back to normal 1 to 2% of failure rate, which is the minimum we can have in all cases. So I propose that you look back at the factors, study about all those topics that can cause bone loss, which will lead to failure, and follow up your patients continuously. Every 6 months, you need to follow up your patients. Before every 3 months will be better, and follow up your outcomes of your treatments. So whenever a problem happens, you can save it if there's a possibility before the implant fails. So that's my advice. Document well, follow up your patients, because I won't be able to know what happened exactly during the procedures, but you will be able to do that.
Thank you very much, sir. Moving on to the next question. Question from Dr. Fabio Manuel Filanino. Do you think that not drilling is going to reach the zero bone loss for the reason we are more conservative for the bone? Example, osteotomes, bone expanders.
Well, hello, my friend Fabio. I'm really happy that you attended the lecture, and it's a beautiful question. Actually, yes, we have different types of not drilling. We have biological drilling at low speed, but this is not actually what you were mentioning, because it is using osteotomes and bone expanders and things like that. How are we going to place it in a ridge? We need to drill first, and then maybe we will not use all the drills in the kit. We'll use maybe a pilot drill and then continue with osteotomes and expanders. But this is also trauma, because anything that is not a healed ridge is trauma. So the moment, it's not only about the trauma, it's also about a foreign body being placed inside the bone. And that's also take us where we use xenografts. Xenografts is a foreign body. It's not part of my body. It's another part. So it's from another species. So having a foreign body can or will 100% start a reaction from the body, whether it will be bone loss, whether it will be rejection. We cannot always control that. So unfortunately, using osteotomes or expanders, I don't believe that they can play a role in that. maybe it can do the opposite by providing pressure and load on the implants, where you can use the tap, tap, and tap, especially on osteotomes, when sinus lifting or expanding the bone. This is also trauma to the bone. It's a different type of trauma. Maybe it's less, but the concept of having a foreign body in the osteotomy site, in the bone, is the main factor here.
Thank you very much, sir. Moving on to the next question. Question from Dr. Neha Gaur from India. Since micro gaps are inevitable, how can we minimize tissue pump action?
Okay, beautiful question, Dr. Neha. There are two ways to use an implant abutment junction that has very little micro movement. Of course, if you have a micro gap, you will have a micro movement. So use an implant abutment junction with limited or minimal micro movement and increase the platform switch. Unfortunately, this has two factors controlling it. The implant design itself, whatever implant you're using, some systems, the maximum platform switch they can achieve is 0.5. Other systems, it can go more with wider implants. And in any system with platform switching is like that. So let's, for example, take system X, for example. If you use a 4 millimeter implant diameter, let's say you have a 0.5 platform switch. If you use a 5 millimeter implant diameter, you'll have 1 millimeter of platform switch. So in any system, the wider the implant, the more platform switch. And therefore, some systems you can achieve even wider platform switch with wide diameters. So if you're placing a posterior implant, try to go, if the bone allows that, if you're at the mesodistal space allows that, try to go for a wider platform implant, like a 4.5 diameter or a 5 millimeter diameter. We don't need more than that, actually, because I believe in the concept of removing more bone is more trauma. So you try, as long as you have enough implant width for support of the load to prevent mechanical failure. Overload will not cause biological failure, but will cause mechanical failure. So we need a wide diameter implant. Then you have more platform switch. And therefore, to answer your question, you're able to move the microgap more further away from the bone.
Thank you very much, sir. Moving to the next question. Question from Dr. Aaron Gomes. Can non-concentric placement of implant cause an increase in microgap? Which taper minimizes such non-concentric placement of abutment?
Okay, so what I believe from your question, concentric patient, non-concentric, concentric, like placing them in a single line, or like we used to say tripoding. I believe if I understood your question wrong, then please tell us. But that's what I believe your question is. If you are placing it in a straight line, it will have, some people say, like if you have two implants in a line and an offset implant, then the microgap effect is canceled. This is with hex connection implants, but we don't need that with cone connection or even more tapered implants. We definitely don't need that, because whether they're in a straight line or concentric or non-concentric, you will not have this amount of micro movement to worry about. So in hex connection implants, yes, that's why Carl Mesh used to propose to place implants in hex connection with a tripoding effect. One of the implants is an offset, but in cone connection or more tapered implants to talk about, it won't be a big problem for that.
Thank you very much, sir. Moving to the next question. Question from Dr. Alicia. Which implant is the best for the patient normally that we can use?
The most simplest to use and the most evidence-based implant, or an implant that has evidence on scientific research and that is simple to use. But accessibility for the components, for everything. So it's you to decide which implant system, as long as it is simple and has scientific evidence supporting it.
Thank you very much, sir. Moving to the next question. Question from Dr. Oways. Does the crestal bone loss cause food lodgement or bad breath?
Okay. Does crestal bone loss cause food lodgement? Well, it's not the crestal bone loss that can cause food dislodgement, is the emergence profile of the crown itself. So if it wasn't made in order for this tissue level to be recessed, and then you have exposed finish lines, or you have part of the abutment exposed, or even part of the implant exposed, then this can cause dislodgement. So it's mainly about the emergence profile more that has the frequency of the food dislodgement. Yes, if you have bone loss, then food impaction, we can say, could be more possible or more possible because you have a rough implant. Most of today's implants are rough. And that's the only drawback when using a rough implant, is that when it is exposed, you need to do something about it because it will keep on collecting plaque. And some clinicians proposed to actually smoothen out the shoulder of the exposed implant. And therefore it will be polished again and it won't accumulate as much plaque as previously happened. But yes, crestal bone loss can cause dislodgement of the bacteria. So in order, or the food impaction. So what causes more frequently we need to worry about is the anatomy of the abutment design itself and the emergence profile. And therefore, that's why the depth of the implant, either in extraction sockets or in heel ridge, is very important because this can affect the final shape of the final crown, which can cause frequent food impactions. And it's not easy to clean sometimes. And also, when we talk about excess cement, sometimes it's not easy to remove due to the shape of the crown itself.
Thank you, sir. Moving to the next question. Question from Dr. Tamar from Georgia. What do you think about bone blocks, and do you use PRF in your operations?
Well, it's not the topic that you're talking about, but of course I'll answer this question. What I think about bone blocks, of course, they're the gold standard for bone regeneration. They are a tool, as every technique we have. It's a tool in our pockets. We can take it out when we need, what is the best for the patient. It's not because I want to perform a bone block that I would put the patient in a surgery that is really sometimes a bit heavy on the patient and a bit aggressive to the patient, in order to take it from the ramus, you need a second surgical site, in order to take it from the chin, from the retromolar, from the tuberosity, from the maxilla, from the skull, from the tibia. All these are excessive surgeries on the patient. So we need to be careful and be sure that without it, we can no longer achieve the regeneration that we want. And then we would choose the bone block. So if you have no other alternative and it's the best option for the patient, then we will go for the bone block. The PRF, I believe, it makes our life more complicated. It only enhances tissue healing in the first few weeks, which I believe takes long to prepare, and it makes your result or your treatment less simple. So I will always like my treatment to be simple, fast, and efficient. Remember, time of the surgery is really important. The longer you keep the flap open and the patient on the operation chair, the more possibility of swelling and infection and inflammation. So time is a critical factor. Yes, I may be saving few weeks in the first 2 weeks of healing, which if you release the flap well, if you use the type of sutures well, and you sutured well, you don't need to worry that much about healing in the first few weeks. But whether PRF would cause or enhance bone quality, it has not been proven by research until today that PRF will not enhance bone quality. But it makes amazing pictures. Like you put an implant, the bone, membrane, and a layer of PRF, and you put these layers, stack them over each other, gives you great pictures. That's the only advantage of PRF, I believe. Other than that, it would slow us down.
All right, moving on to the next question. Can the convergent structure affect stability of apical migration?
Convergent structure affects stability of apical migration. I believe you're talking about the abutment. So yes, the more parallel the walls, or let's say convergent, but not that convergent, of the abutment walls, parallel of the walls of the abutment set, and not being divergent, it will prevent the connective tissue to be formed on a lower apical layer, and therefore epithelial cells will migrate more apical, and therefore you can have recession or bone loss. So yes, it does holds the connective tissue attachment above the implant shoulder directly.
Thank you, sir. Moving to the next question. Question from Dr. Simran. What are the various complications associated with angled abutments used primarily to get proper restorative contours, and how to overcome them? Any alternative suggested?
Okay, first of all, it's a beautiful question because angle abutments, they were actually thought to have an effect on crestal bone loss. And studies, they showed that what angle abutments does, it causes overload, and overload cannot cause bone loss alone. It has to be with inflammation or infection. But I believe that angle abutments are a tool to use when you made a mistake in the positioning or the angulation of the implants. It shouldn't be there to use whenever we want. It should correct something wrong with it. Therefore, we have the companies providing us with angle abutments from 7 degrees, 15, 30, 35. So when we have made a mistake in the implant placement, we could use the angle abutments, even in central, upper central. We don't need angle abutments. If you place it, sometimes the bone limitation or the contour, the anatomy dictates us to place an implant in a certain position that we will need angle abutments, especially when the relation with the mandible and maxilla dictates that. Then this is a situation where we have to use an angle abutment. Other than that, we should always try to use a straight abutment. Today, some systems provide screw access through a lingual channel in order to use the screwdriver in the same manner, but the screws or the screw head are designed in a certain way. Not that easy to torque at a certain level, but sometimes there's a possibility. So for a solution for that, I will always tell you just to be sure that the moment you place an implant, check the occlusion, allow the patient to bite and check that the implant is placed in a correct position. And you can actually have a transfer coping or transfer post or an abutment. Just place it at the implant during placement, after placement, and check that you will use a straight abutment. If you find yourself going and being an offset angle from the occlusal table of the opposing teeth, then try to correct your angulation. Therefore, you will most of the time utilize straight abutments. When I started to do this, to be honest, I used to use angle abutments frequently in the past. And when I started to utilize this technique, make sure that the angulation of my implant during placement will allow for a straight abutment by checking the occlusion of the patient during placement. Today, I rarely utilize angle abutments. So this is something, maybe a trick that you can utilize.
Thank you, sir. Thank you for answering it so well. Moving on to the next question. Question from Dr. Manasi once again. Why is the lingual flap left intact in the soft tissue?
Okay, why lingual flap is left intact in soft tissue? Well,
Yes,
this
sir.
is
That's the
only,
question.
yeah, this is only to measure the vertical soft tissue thickness. But after you measure the soft tissue thickness, because if you reflect the buccal and the lingual, how would you measure the thickness of tissue above the bone crests? So you first reflect the buccal, then you measure the tissue thickness, and then you reflect it like you can see it here on this image. You reflect the buccal and the lingual. So you don't leave the lingual flap always. You always reflect the buccal and the lingual to see or visualize the bone contour completely.
Thank you, sir. Moving on to the next question. Question from Dr. Kumar. Greetings, sir. It was an eye-opener information and you provided excellent information on soft tissue management. The question is, what's your take on using, I'm not sure if it's Emdogain or if it's Endogain or PRF for thickening of thin gingival biotype?
Okay. Thank you for your greetings, Dr. Kumar. It's a great question. Emdogain or PRF for thickening of thin gingival biotype. Well, as I said about PRF, Emdogain, sometimes we are able to have it ready from a company. We don't need to manufacture it or to prepare it, let's say, as PRF. I believe as much as you can to keep it simple is really better for your patient and for yourself. You save time, you save money, you save energy, you save effort, as long as this won't alter the final outcome of our treatment. So, and again, there's a lot of studies that improve healing, and you just put it on the surgical field with a syringe. it might improve treatment in the first few weeks. Growth factors, a lot of growth factors that you can utilize in severe cases with guided bone regeneration. Yes, I might tell you it could be beneficial to have a severe case of guided bone regeneration, but other than that, I don't. Scientific evidence haven't showed that it can improve the quality of treatment outcomes. So it's up to you whether you would actually use them or not. I wouldn't use them because they would take time to prepare or take money to more expenses on the patients. Exactly like drilling. A lot of clinicians today, they are following a technique to drill anastomosis site where an immediate implant placement in the molar through the tooth. And I believe this is harder actually than drilling it after completely extracting the tooth and then start to drill. Because if you drill through the tooth, what you're doing is that you're covering the interceptor bone that you actually want to assess whether to drill through it in the first place or not. So if you have the tooth covering it, you drill through it, and then you remove the two root fragments after you finish drilling, and you find that you have no interceptor bone because you just drilled through it. So it's a lot better if you remove the teeth and then assess what you have. Sometimes making things complicated is not the best way unless it provides a better treatment.
Absolutely. Yes. So moving on with the next question. Question from Dr. Sitaram. So does primary stability play any role in progressive loaded implants?
Okay, so this Dr. Sitaram, it's a beautiful question because progressive loading is a really useful protocol that we can follow, especially immediate loading cases and delayed loading cases, where some authors or some clinicians, they propose to progressive load implants in any implant case, whether you had primary stability at the start or we didn't. And primary stability, we can ask it in a different way. Do we need primary stability to have successful osseointegration? The answer is no. We can have spinner implants that will osseointegrate. So in these cases, yes, of course, I would always progressive load the implants. And for those who doesn't know what progressive loading is that you temporize, you start loading by using temporary restorations, acrylic restorations that have less load on the implant. And then after 6 weeks, you transfer this temporary restoration to a final restoration with a ceramic crown or a metallic crown, whatever type of restoration, but the final crown. This what does it does like trains the bone and ensures that the moment you put the final load on the implant, you have good or complete remodeling of this weak bone that you started with that led to a weak primary stability, low primary stability. So yes, primary stability, of course, if you have low primary stability, I would always go for progressive loading.
Thank you, sir. Moving to the next question. What is the maximum jumping distance you can allow without grafting in case of immediate implant placement?
Okay, thank you, Dr. Sitaram. Very beautiful question. We talked about that in previous webinars I had in the past few weeks, and I'm going to answer that clearly. The maximum jumping distance that you can have is unlimited. I believe it depends on the extraction socket itself. So I don't think if I have an extraction socket with a 10 millimeter diameter, I'm not going to place an implant. I'm going to extract the tooth and dismiss the patient. And I have a 10 millimeter diameter of socket. And I know studies have showed and they conclude that above 3-4 millimeters, then or 5 millimeters, I think it was 5 millimeters, then you need to fill the gap because otherwise you won't have enough bone to implant contact. What if I extracted a tooth that has a diameter of millimeters? I need 5 millimeters. I'm not going to do anything. What should I do? Should I fill the gap, the whole socket with bone particulate material? Or should I try to minimize the dimension of the socket? I don't know how, but I believe that if we don't do anything in these cases, what happens is that they heal and they are completely filled with bone. So placing an implant in a socket will make that much of a difference. Filling the gap or not is the way I look at the way literature has clearly showed us is based on providing contour, the need of providing contour to the buccal tissue or not. So if you need contour for the buccal tissue, you can go ahead, fill the gap. If you don't, it has no effect on the amount of bone formed in the sockets because the socket will fill by bone anyways, whether you fill it or not.
Thank you, sir. Moving to the next question. What do you think about flapless surgery?
Okay, flapless surgery is beautiful and it saves time, easier in the first few hours of the surgery, and then it will not save you time after that, because flapless surgery, it has a very high risk of placing an implant in a wrong buccolingual or three-dimensional position. And a lot of cases that we have seen where the implant was placed in a strange buccolingual dimension or position, I would go back to how the surgery was done. I would find out it was done flawlessly. The problem is it's a lot faster, it's a lot safer, it's a lot relaxing to me when I see the bone that I'm drilling through. So opening a flap, if you open a clean incision, clean cut incision, if you suture it well, it shouldn't cause inflammation, and inflammation will happen anyway. Even if you drill and you do it flaplessly, there will be inflammation because you place an implant. Placing an implant is inflammation. It will have to happen. If you place an implant, as Aberkson showed us, you will have inflammation, but then it should be like resolved. So opening a flap with a clean incision and suturing, the swelling should not be that much. Sometimes it's never there. With the proper medical prescriptions and clean surgery, you shouldn't have a problem. It's not a debate why I would need to go flapless, because it's less pain on patients. Sometimes placement of the implant doesn't take time, unless I'm using guided surgery for immediate loading, for example, or for a medically compromised patient. Then guided surgery, yes, I would somehow utilize a flapless technique. Although even myself, even if I have a guided surgery, I would like to have a tooth supported in order to open a flap and see what I'm drilling through. I always trust my eyes, and I just can't trust anything else. So flapless surgery, I wouldn't recommend unless you follow bone mapping technique, where you have to measure the bone, this tissue thickness, and translate it to a master cast and to a study cast, and know exactly where you're placing your implant, which is takes a long time.
Thank you very much, sir. Moving on to the next question. Question from Dr. Aaron. In case I have placed implants and I ended with 1 millimeter crestal bone loss after 1 year of loading, can I augment soft tissue thickness and do bone grafting for the crestal bone loss and be sure that there is no more crestal bone loss?
Okay, so if I replace, there's a question was before that, but we're going to answer this first. If I placed an implant equicrestal and you had 1 millimeter of bone loss after 1 year, that's what Dr. Allen said. Can I augment soft tissue thickness and do bone grafting? Well, do you need that in the first place to augment this 1 millimeter of bone loss? What if you still have the implant totally covered by tissue and you have nothing exposed, no effect on the function or aesthetics? Do you need to do anything? That's the first question you should ask yourself. Now, if the threads of the implants are exposed, from this one, utilize soft tissue procedure, connective tissue grafts, de-epithelialized connective tissue grafts, for example, to cover this amount of tissue recession, as you clearly have shown us in a lot of studies and a lot of clinical evidence that we used ourselves in order to correct complications around or correct defects around soft tissue defects around implants. So yes, we do this a lot. We are able today to correct soft tissue defects around implants utilizing soft tissue grafts or connective tissue grafts, sometimes free gingival grafts. So yes, it is possible. To go for bone grafting, I wouldn't go there unless I have nothing else to use. 2 or 3 millimeters, they can be corrected using soft tissue grafts alone. As long as you have thick tissue on your implant, even though they have no bone, it will sustain in a long period of time. So I wouldn't go for treating using bone grafts. The success rate of it is a lot less. You can, sometimes it is successful, sometimes it's not.
Thank you, sir. Moving to the next question. I'd need your help here with the pronunciation. Some recent studies talk about hyaluronic acid. Hyaluronic acid, yeah, and healing enhancement. Do you think so?
Well, hyaluronic acid has been used for hair treatment, for skin treatment. It has been used for a lot of things. I believe since it's not that expensive and we buy it, we don't prepare it, and some studies have shown to have a small beneficial to sinus augmentations, for example. So if you have, I will believe if you have a big surgery, a big augmentation that would need all the tools I have, it could be a solution, or not solution, but a factor that might improve formation of bone. It might. There's no clear evidence of hyaluronic acid, but it's a product that can enhance healing and utilize growth factors to enhance the healing of augmentation or soft tissue grafts. Sometimes you can place it on the implant itself before placing. So it could be utilized, yes. We need more clinical evidence to whether it will definitely be used in every single case or not.
Thank you, sir. Moving to the next question. Question from Dr. Mustafa. Do the customized abutment will decrease the crestal bone loss more than the stock abutment?
Well, this is Dr. Mustafa, a beautiful question. Use a custom abutment or a stock abutment? Well, the stock abutment, the problem with the stock abutment is that it doesn't always provide the width for attachment of tissue according to aesthetic needs. And this is mainly in anterior aesthetic cases. So in posterior cases, yes, it might have no difference. We used a lot of stock abutments in the posterior cases, and a lot of literature have used in their studies stock abutments. So in posterior cases, I don't believe it will make that much of a difference, but in anterior aesthetic cases, it would definitely make a big difference, because whether it's a titanium customized abutment or zirconium customized abutment, it would follow the contour of the tissue architecture that you have prepared using your temporization. So you want your prosthetic abutment to take this contour and transfer it to the final crown, from the temporary crown to the final crown, and use this contour by customizing it digitally to follow the exact same contour, transfer to the abutment. So yes, in aesthetic cases, I believe it plays a big role.
Thank you, sir. Moving to the next question. Question from Dr. Sitaram. Sir, does closing flap with cyanoacrylate affect crestal bone?
Well, I've read a lot of, not a lot, but a few studies about cyanoacrylate, and I don't see a need where we can use this. And there are also points about chlorhexidine. So there's a lot of debate about materials and components and materials that can affect the crestal bone level. Keeping everything simple is the best way. The really important factors are the soft tissue thickness, the implant design, the clean incision that you do at the start, the heat generation that you prevent during drilling. That's why we use copious irrigation. Sometimes we use internal and external irrigation. It's really important factors that can cause surgical trauma and can cause bone resorption during actually the first few weeks of the healing period. And all these factors are a lot more important. The suture that you use, some suture materials that they just collect, they're a magnet for food debris, and therefore can cause inflammation to the tissues, which can prolong and therefore cause bone loss in the future. So selecting the right material as simple as possible, as few materials as possible, using a simple implant system, using a simple drilling protocol. I know today we have different drilling protocols. We have the biological drilling, we have dense subbers or reverse subbers with osteodensification. All these things, they are tools in our hands. Whether we want to use them or not depends on the requirement of the situation. Whether you want to spend time or excess time using PRF or preparing PRF, using osteodensification drills, which does take time more, like it is extra time. So it needs care and a lot of techniques. I'm not saying dense osteodensification is not a tool. It is a perfect or amazing tool that we can use sometimes. Cyanoacrylate, you can use them. All hyaluronic acid, PRF, all these scenarios. Chlorhexidine, you can sometimes inform the patient to rinse after surgery, but then you need to be careful because some studies have shown that chlorhexidine can affect remodeling. And therefore, we need to be very careful with the materials that we're using, They have to be backed up by scientific evidence. If not, we can use them with caution, and then keep it as simple as possible. Make this treatment for your patient according to his needs. Try to keep it as simple, as fast, and efficient as possible in order to achieve a successful treatment. And therefore, using these biomaterials or any biomaterial has to be with caution. Unless it's really required for our treatment, then we would go for it. Other than that, keeping it simple is always the best scenario.
Thank you, sir. Now taking questions from the other social media platforms. Question from Dr. Ashraf Ali. I have been a Most Taper Connection fan and a good user of similar implants in my practice. Since all my Most Taper Connection implants are subcrestally placed, do you think the same connection works in tissue level implants?
Well, tissue level implants, I don't see why would they need a more stable connection in a tissue level implant, because you don't need platform switching. You don't need, the microgap is already far away in a vertical direction. There's a vertical offset. The beauty of soft tissue level implants is that it moves the microgap in a vertical offset, not a horizontal offset. So you can move it horizontally in a platform switching, or you can use them vertically, move it vertically in a soft tissue level implants. So soft tissue level implants, they move the microgap away from the bone crests, and therefore I don't need platform switching. I don't need a more stable connection, but we need it for better mechanical stability. So I don't know of a tissue level implant with more stable connection. The famous tissue level implants that we know about are the Swiss Plus and the Straumann tissue level. They are not more stable. One of them is a hex and the other is a cone connection. So I haven't seen a tissue level implant with more stable connection. There is with cone connection, but not with more stable connection. So I'm not a big fan of soft tissue level implants, because soft tissue level implants, they need very thick tissue. Yes, they could be utilized in the posterior area, and they are made for posterior area. Of course, we won't use tissue level implant in the anterior aesthetic zone, but they need very thick tissue, and they need very meticulous placement depth, and be sure that you're placed in the correct depth and you have enough tissue thickness, and you can utilize it in a one-stage protocol, and therefore it needs some certain requirements. Bone level implants or subcrestal implants, they don't need these meticulous requirements. They're more simple to use. So that's why I prefer sometimes to use, or most of the time, to use bone level or subcrestal level implants, especially for implants that can be placed subcrestal position.
Thank you, sir.
In soft tissue to have a more staple, I've never seen that.
Thank you, sir. Moving to the next question. Can we increase better bone remodeling using Most Taper Connection?
Well, using a more stable connection it will not, let's say, actually there's a difference between crestal bone remodeling and crestal bone loss. Crestal bone remodeling, to be clear what we're talking about, is where the bone will stop to remodel. It can stop at the crest of the bone, or crest of the implant shoulder. So bone can remodel to reach the implant shoulder and stop. When it continues below that, that's crestal bone loss. So there's nothing wrong with bone remodeling. Bone remodeling should happen. It will happen. But if it continues beyond the implant shoulder, it is a problem. It's called crestal bone loss or marginal bone loss. So whether we have the relation between the Morse taper and the crestal bone loss is two things. The microgap moving away from the implant shoulder, and therefore we have platform switching, which causes the microgap to move away using a Morse taper connection, because Morse taper connection will always have a platform switch. And the micro movement, or the minimal micro movement that is there, and the minimal, let's say, tissue pump action that is actually shifted inward by platform switching. So yes, Morse taper connection can enhance, or let's say minimize, crestal bone loss according to a lot of studies. And when I started to study that, because actually my thesis was about this topic, the effect of abutment implant connection on crestal bone loss, my master's degree, and I measured whether it is beneficial for bone remodeling, or sorry, crestal bone loss, to use a hex connection or a Morse taper connection or a cone connection. Which one is better for crestal bone stability? And what I found out is that a lot of misleading information that we can get from studies, because some studies, they start to measure bone loss after loading. And what I found out is that most of these studies who measure bone loss after loading are implants with cone connection or Morse taper. On the other hand, the studies with hex connection implants, they study the bone loss from the start or day of implant placements. This is a very misleading point. Why? Because if you place your implants at the day of placement and you start measuring the bone loss, there's the first 3 months has no effect from the implant abutment connection. You haven't connected your abutment yet. You haven't loaded your implant yet. So the bone loss that happens in the first 3 months of healing, which is the most amount or the greatest amount, if it happens, due to surgical trauma, due to medical condition, due to anything. So the pre-loading phase is not related to the loading phase of bone loss. And what the implants with cone connection they were doing, because they were emerging in the market, I believe that's my analysis of that, is that since they were new in the market, they knew that if they measure from the loading phase, they have minimal, very minimal amount of bone loss. And that's why in the studies that I showed you, where they were done in the late 90s and 2000s using Astron, Noble, Bicare, and Straumann implants, they were very old studies. Not today, it's old, it's in 2005 and 10, 11. They measured all the implant or the crestal bone loss starting from loading. And therefore, they had minimal bone loss. And they compared it to studies that measured bone loss from the day of placement. So what I found out, yes, crestal bone loss can be limited using or decreased using Morse taper connection, because it can be used in a subcrestal manner. It can be used with a platform switching possibility, with totally off implant, minimal micro movements. It's a better mechanical assembly, but it doesn't mean it is superior. It is more predictable, I can say, in thin tissue. It provides more solutions using without using extensive surgeries. And yes, it is a good solution, but it has some mechanical disadvantages also, like removing of an abutment after many years of service. It's not easy. If the system doesn't have a retriever or an abutment retriever, it's a problem. Fortunately, we're lucky that most systems today, they have an abutment retriever in order to push the abutment out, because it's impossible just to remove it by your fingers. You need a forceps, which will deform the abutment. So you need an abutment retriever. So this is solved today. But the only thing that is not solved is if a part of the abutment fractures inside the implant, it's not that easy to remove, especially Morse taper implant connection. Other than that, I believe it's the best solution for an implant to be used, to use a Morse taper or cone connection implant, as we say, either of them. But it definitely has a big effect on minimizing crestal bone loss.
Thank you, sir. Well, that brings us to an end of the lovely question and answer interactive session. Once again, if you can see in the chat box, we have a flow of happy birthday messages. Along with those, on behalf of Team DentistChannel.Online, once again, Doctor, thank you so much for your valuable time. Thank you, friends, for participating and being so interactive. A certificate of participation would be given to you on your registered email within 3 working days. Once again, with this, we come to an end. I look forward to seeing each and every one of you for all the webinars. Thank you so much, sir. May you have a good day.
Thank you very much for all the attendees, and thank you all for the amazing birthday wishes. And I would like to thank all of you for this interaction. And I hope you all a good evening and a great day. And the coming days will be a lot better than the previous ones. And hope you are all safe and in perfect health. And looking forward to seeing you again to share more knowledge and information together.
Likewise, sir. We'd love to have you once again. Thank you very much once again. Have a good day.
Thank you very much.